Good morning, good evening, from wherever you all are attending from. Thank you for joining us today. It is much appreciated, and we're very excited to deliver some amazing sessions to you all today. So my name is Dapo. I'm from the TaskUp Global Consulting Group, and I'm supporting the Congress with all technical support. So I'm going to introduce our moderator for today's session, Mr. Delaney Hines, and then he'll take it over from there. So Mr. Hines excels in building relationships and forming partnerships to promote equitable health outcomes. He's dedicated to advancing health equity, particularly in cardiovascular and cerebrovascular health and sickle cell anemia. Mr. Hines serves on the board of the Sickle Cell Awareness Group of Ontario and has a background in supporting health programs at organizations like St. Michael's Hospital and Mount Sinai Hospital. Mr. Hines holds degrees from Carleton University, Western University, and Quantic School of Business and Technology. Mr. Hines, please take it away.
Thank you, Dapper, for that warm welcome. And to my point, my colleagues' earlier comment, good morning, good evening, and thank you so much for joining this year's Gantt Congress. Just to confirm you're all in the right place, this session is a diagnosis and management of inherited blood disorders in low to medium resource countries. And the session objectives include identifying and managing hemophilia disorder in low to medium resource countries, identifying and managing thalassemia disorders, and identifying and managing sickle cell disease in low to medium resource countries. I'm joined by an esteemed panel alongside my colleague Dapo, who I have the pleasure of introducing. But before doing just that, I want to make sure that I allow folks to get familiar with the different tools and the actual logistics for the session. So as you've already seen, the session will be recorded for viewing at a later time. We've also placed all folks participating in the session on mute as to ensure we have a steady, seamless flow throughout today's program. And also, we'll be displaying a poll toward the end of the session for folks to submit their comments, feedback on just the actual delivery and presentation. And then once again, if there are any questions, feel free to use the Q&A option, which you'll see located toward the bottom of your toolbar. We also have a captions option, which is you'll see a little small box with a CC, which you can enable for translation. You can also update the speaking language to ensure that the transcript or the captions can be displayed in whatever language you prefer. So that's the housekeeping. And as always, if you have any questions for me or anything you're not clear on, just feel free to use the chat box. We'll be sure to keep a keen eye on that. So joining me on the screen, we have Dr. Mandy Yap, who is joining us all the way from Malaysia. Thank you so much, Mandy. She's a clinical hematologist who's looking after thalassemia patients in Ampang Hospital. She's done her fellowship in hemostasis and thrombosis at Perth, in Perth, Australia, and she completed her fellow Royal College Fellowship in Pathology from the United Kingdom in the year 2022. She's currently the president of the Malaysian Society of Patient Blood Management and is joining us for the first time. So without further ado, I'm going to turn the virtual microphone to my colleague, Dr. Mandy Yap, who'll be walking us through her presentation on diagnosis and management of hereditary blood disorders. Over to you. You're just currently on mute, Dr. Yap. There we go.
Right.
Perfect.
Can you hear me?
Yes.
Thank you. So I'll be talking about diagnosis and management of hereditary blood disorders in the low-medium resource countries, which is mainly thalassemia. Thanks for the kind introduction, Delaney. Yeah. So I'll bring you through the prevalence of thalassemia, diagnosis of thalassemia management, as well as followed by some case scenarios, and last but not the least, a summary. So I'll tell you with regards to our latest Malaysia Thalassemia Registry, which I went to have an important meeting with all the stakeholders back in 2023. So the current latest updated number in the country is about 10,776 in Malaysia. And we have a cumulative reported deaths about 1,222, 11.3% out of the 10,000 over patients. And the death in 2023 last year was about 108 patients, which is quite significant. You can see the thalassemia burden in this particular country. Now, this is the distribution of thalassemia patients in Malaysia according to the age group by the state. So we have about 14 states in our country, which you can see the highest bar is actually in Sabah, which is in North Borneo in Malaysia, followed by Selangor, which is a center that I'm in now from Ampang Hospital. We have about 958 patients in one center alone. And you can see third will be Kedah, and then followed by other states as well, like Kuala Lumpur. This is the gender distributions. As you can see, the main one, the leading is actually females, 52.67%, in comparison to 47% of males thalassemia patients. Now, this is the thalassemia patients according to the ethnic groups, the distributions. In my country, the majority of the ethnic group would be Malay, consists of like about 70% of the populations. So, of course, logically, they will be the majority of the patients, 66.25%. But surprisingly, the second largest ethnic group, like Chinese, is actually falling behind to the indigenous group. You can see the Kadazan Dusun over here, which is mainly explained by the Sabah being the highest number of thalassemia patients, because you can see they are this group of indigenous patients mostly come from Sabah state. And you can see the third one, fortunately, which is the Indian, being the third largest ethnic group in my country, is very minimal. It's only 0.66. Whereas for Chinese, being the second largest, is 10.23. And the rest of this Bajau, Murut, Rungus, Sungai, and others, they are actually indigenous group as well, mainly from Sabah as well as Sarawak. And the distribution of this group of thalassemia patient according to the diagnosis. So unfortunately, the access to molecular diagnosis of thalassemia is still limited. It's up to only 50% roughly at this stage. So mainly they are all diagnosed by HP analysis. So you can tell that majority of them is E-beta thalassemia in my country, 37.58%, followed by beta thalassemia major, 28.12%, and then beta thalassemia actually is alpha thalassemia, sorry, HPH disease, 22%. Last is the beta thalassemia intermediate, 8.7%. So this is actually the algorithm that was suggested by laboratory diagnosis of thalassemia, how we actually come about the diagnosis of, to derive all this important diagnosis to patients. So of course, namely, because it's autosomal recessive, it should be suspected from family history or anybody who presented with medical history suggestive of chronic hemolytic anemia, like thalassemia phases, malahyperplasia, you know, as well as hepatosplenomegaly, short stature, yeah, or even suspected from full blood count indices like hypochromic microcytic, MCV less than 80 femtoliters, MCH less than 27 picograms. But of course, you have to be careful. This hypochromic microcytic anemia, it also can point towards iron deficiency anemia at the same time. So what makes the difference between iron deficiency anemia and thalassemia? Basically, if you look into full blood count, essentially we will look into red blood cells, the RBC indices, because in normal people, the hemoglobin divided by 3 would be the normal range for RBC. For example, if your HB is 12, your RBC will be divided by 3 is 4. But if thalassemia patients, the RBC will be inappropriately raised, like 5 to 6. Yeah. And then after that, you look at red cell distribution width, whereby you can see them like in thalassemia normally is quite normal, whereas for iron deficiency anemia, it will be markedly raised. And again, you can look into the peripheral blood film, where you can appreciate a microcytosis hypochromia. And in those with thalassemia, it will be obviously with a lot of red cell anisopoikilocytosis. Basically, a lot of red cells with different size and shapes, and a lot more target cells, and sometimes with additional features like basophilic stippling, as well as recladated red, and also alpha inclusion bodies, which essentially not present in iron deficiency anemia. Iron deficiency anemia, on the other hand, in the blood film, you may basically see like pencil cells, just hypochromic microcytic. And the one you can see plus and minus inclusion bodies, which is HPH inclusion bodies is basically has to be stained by a supravital stain called brilliant crystal blue. Yeah, in the full blood count, you can see like a golf ball appearance, which a lot of the lab, including my lab, I don't really do it anymore because we have access to DNA analysis now. We can just send it and confirm the diagnosis of alpha thalassemia. Of course, if you have, on the other hand, you suspected iron deficiency, you can do iron studies. And most of the time, your ferritin may come back low. And this particular journal, I think they use a cutoff is rather low, like 12 nanogram per mils. In fact, nowadays, I think we have raised the bar of ferritin for iron deficiency because there's a new entity called iron deficiency, basically like ferritin less than 100 or even less than a 50 nanogram per mils. You should actually consider or suspect iron deficiency anemia. And whenever you suspect thalassemia, you should always think of HP electrophoresis or even HPLC. And for that two different method that we use, essentially we are looking into similar parameters, which is your HbA2, A2 hemoglobin, more than 4%. In fact, in nowadays, people has brought down the A2 cutoff for capillary electrophoresis, for example, like Serbia. Yeah, we brought it down to 3.5 in order to capture more thalassemia patients. And the HbF is 0.1 to 5% for thalassemia trait. Whereas for those with alpha thalassemia traits or related disorders, it's also the same. You can see a similar finding, HbA2 less than 4, the fetal hemoglobin less than 1%. So what we have to do is, HB analysis is not helpful in these particular disorders. We have to send for alpha DNA analysis to confirm. And whereas for beta thalassemia intermediate, the only difference is the fetal hemoglobin is like 5 to 50%. It's much more, but there's still presence of adult hemoglobin, HbA, basically, which is not illustrated in this algorithm. Whereas for HPH disease, it's basically alpha thalassemia with 3 gene deletions. They usually have a HPH kind of spike in the capillary electrophoresis, 5 to 25%. And the A2 will be less than 4%. And sometimes you may be able to see the heavy chain like constant spring in this particular patients, and it will become a non-deletional alpha thalassemia, which is essentially a more severe clinical manifestation. Okay, other HB variant, you name it, like my country has a lot of E hemoglobin neuropathy, you can see with the E beta thalassemia. And also, fortunately, we don't have HBS much disorders, or HBC is really, really rare in my country. And of course, another one, DNA analysis for beta globin mutations, which is essentially very important for us as well to characterize the patient further. Now, this is a hematological data just to illustrate how to differentiate thalassemia major, thalassemia intermediate, and E beta thalassemia. Yeah, you can see thalassemia major, especially for beta, the HB level normally is at less than 7. For thalassemia intermediate, 7 to 10. Whereas for E beta thalassemia, on the other hand, the clinical phenotype or even the HB level itself can be very wide ranging from 9 to 12, 6 to 7, 4 to 5. Some of them is really severe until like Tau major that we need to transfuse them every 2 to 3 weeks. You can see the hemoglobin study, basically, you can talk about DNA analysis, yeah. Basically, in Tau major, mainly is beta 0, where your fetal hemoglobin up to 35%. A2 is more than 5. And beta 0, beta plus, which you have HbA, yeah, that's what I was talking about. That's the difference between thalassemia intermediate and Tau major as well, up to 30%. And fetal hemoglobin is 70 to 90%. And this group of patients will need transfusion dependent. Whereas thalassemia intermediate is 10 to 50%, HbA2 more than 4%. And for E beta is very variable. E can be 40 to 60, fetal hemoglobin 40 to 60 as well, and represents plus or minus adult hemoglobin when the A2 is raised generally. And this group of patients, the transfusion requirement, the intermediate and the E beta, can be due to infections, pregnancy, or growth failure, so on and so forth. Now, this is a blood film I was describing just now. If you pay attention to what I said just now, if you realize the blood film on your left is the one with homogeneous red cells, hypochromic microcytic, with the pencil cells over here. So there's occasional targets. So if you compare to the one on your right, with so much of all these different size and shapes. Some of them even look like fragments. In fact, in a thalassemia case, it's actually irregularly contracted cells. And you can appreciate there's a lot of targets. And some of these targets, when they become so concentrated on one side, they're basically due to the excess alpha globin chain that precipitates in a mature red cells, forming these alpha inclusion bodies. Yeah. So it's not really a target. If you look at that, if you appreciate here, there's like a hemighost cells, like there's a pseudo membrane here, which is so different from iron deficiency anemia. So the one on your right is basically a thalassemia. The one on your left is iron deficiency anemia. So this is a manifestation, or I would say that is complications that will arise after patients become transfusion dependent thalassemia. Basically, they will experience a lot of fast rate of iron overload. You can see they can have pituitary dysfunction, hypothyroidism, hypoparathyroidism, cardiac siderosis, iron overload in the heart, causing arrhythmias, heart failure, which is the main contribution of their mortality and morbidity. And of course, for those who are really badly chelated, iron overload, they also get liver fibrosis, cirrhosis, hepatocellular carcinoma. We have a few cases in one of the prevalent state in Sabah. And of course, last but not least, you can see diabetes mellitus, hypogonadism that contributes to infertility. Well, but in my country, I don't really see fertility problems in my patient. That's why the incidence is really high. And you can see bone disease as well. They easily get osteoporosis. You can get fragility fractures. And of course, for ineffective erythropoiesis in a non-transfusion dependent thalassemia, they have a slower rate of iron overload from increased intestinal absorption of the iron. But they will present to you with silent strokes, hypothyroidism, pulmonary hypertension, also similar complications like the one transfusion dependent, proteinuria, glomerular hyperfiltration, hypogonadism, venous thrombosis, leg ulcers, as well as bone disease. Now, this is a management of thalassemia. Essentially, those days people diagnosed trait, intermediate to major, but now people are divided into non-transfusion dependent and transfusion dependent. Basically, you can see non-transfusion dependent is those beta thal intermediate, mild to moderate E beta, alpha thalassemia intermediate, and the HPH disease. When they need, sometimes they may have increased requirement due to surgery, infection, pregnancy, or even you have to give them like 3 to 4 times a year due to poor growth, or sometimes extramedullary hematopoiesis, or specific morbidities. And of course, for trait or beta thal minor, you wouldn't need transfusion. And for those regular lifelong transfusion will be, of course, applicable to beta thal major. Severe E beta, I was showing you some of my patients, alpha thal major as well, basically the hemoglobin bars, hydrops fetalis. So the treatment, apart from blood transfusion, of course, the iron overload, you can see the picture I illustrated to you, is iron chelation therapy. So what we have 3 main one, which is desferoxamine, which is the parenteral one via intravenously or subcutaneously through an infusion pump, 20 cc of the syringe. The problem with this particular administration of the medication, it needs very high commitment from the patients. The patient needs to administer to themselves subcutaneously using a thalassac needle 8 to 12 hours per day. And a lot of patients basically cannot comply to it. And secondly, we have is deferiprone, which is an oral form of iron chelators. He has to take also 3 times a day. Yeah. And this particular drugs has been quite notorious associated with neutropenia complications. The most scary one is agranulocytosis. We have few patients that we have to really switch to other form of iron chelators, which is like X-Jade, or we call it desferoxerox. Yeah. But this particular drugs, unfortunately, is a bit more pricey and it's not widely available. So far, we only give it to, because they have a lot more data in pediatrics. So we give it to pediatric population more, and he has a association with renal impairment. Now, the third one, of course, is also very important because it's a chronic hemolytic anemia. So it will need a folic acid supplements. And on top of that, because you saw the picture I showed you, it has a bone disease as well, like osteoporosis, right? So generally, we will give calcium lactate or calcium carbonate together with Rocaltril, the vitamin D supplement to them. Okay, so you can see in the bottom here, there's hydroxyurea as well, which essentially we gave it to some of our beta thalassemia intermediate like E-beta, try to increase the fetal hemoglobin in order to bring up the hemoglobin for this group patients so that they become not really require transfusion frequently. Of course, this one is low iron diet, and will be done by our dietitians. And these two, we had bone marrow transplantation available in our country, which mainly by matched sibling donor using allogenic stem cell transplant. So far, we have done about 100 over patients with about 3-4% of out of all the patients. Yeah, and this is a gene therapy, which is nowadays is a current advancement, which is by Bluebird. Is using lentivirus vector incorporated into the beta globin gene. Essentially, you have to undergo an autologous stem cell transplant, like harvested the stem cell and give it back to the patients. And of course, there's also latest technology by gene editing like CRISPR-Cas9. Now, this is my case one. I have a 39-year-old thalassemia major diagnosed at 2 years old on a 3-weekly transfusion back in 2014. So this particular gentleman, he's unfortunately had osteoporosis. He's quite short and similar height as me, and you can see I'm quite small frame as well. And he unfortunately has an agranulocytosis secondary to deferriprone treatment, so we have no choice, have to stop him and put him on only Desferal, 2.5 gram daily for 5 times per week. And this particular gentleman also came down with chronic hepatitis C infections. I can tell you back in early days when we transfuse our patients, the blood was not really being tested for hepatitis C. So some of these patients, unfortunately, got contracted the hepatitis C, and eventually I think he underwent the treatment and got cured. And the liver and spleen is palpable, like 4 centimeters and 9 centimeters each. So he was given folic acid, vitamin C as well because of the Desferal. It will cause vitamin C deficiency, and also vitamin D together with calcium. You can see when he's on single Desferal, his ferritin is 4,100. I can tell you this particular gentleman not really have issue with compliance, like, because he himself is a notary public. He's a criminal lawyer, and he was really compliant to the transfusion schedule. So his transfusion THB like 9.2. And his MRI T2 star was actually normal myocardial, no iron overload, even including the liver, thank God. However, when he complained of it of body ache. So we looked through the x-ray, we noted actually has some paravertebral extramedullary hematopoiesis. So
Dr. Yap,
we have no choice.
just letting you know,
Yes.
you have we have to maybe about 2 more minutes. I know I gave you extra time since one of our speakers didn't show up, but we're gonna probably have to wrap it up in about 2 more minutes.
All right, I'll finish up with this particular case then. So
Fantastic.
we added Syrox afterwards, 1.5 grams. So you can see his ferritin improved to 665, and the pre-transfusion HB unfortunately keep on not being optimized. So at that time, 6 to 6.9. I just cut the story short. He basically over the years he developed actually HB keep on dropping, falling. You can see despite the frequent transfusion up to 2 weekly, he actually developed hyperhemolysis 4.6 with the LDH raised 488. You can see this is the blood film with the hypochromic microcytic, a lot of spherocytes with polychromasia. So that's what happened to him. He actually has a genotype being done. It's a R1, JK pos, B pos, Duffy pos, as well little k, and a double N and small s. And all the rare blood group system is actually as such. I think you can go through afterwards. So what I want to tell you is he has alloimmunization over the years. That's why the HB is not optimized. Allo anti-CW, anti-BK, and the anti-AND. That's the reason why he has hyperhemolysis. You can see here, we actually treated him with pulse steroids, IVIG, and the Coombs is positive, haptoglobin is low. And then subsequently transfused as well, but the HB didn't pick up until we have to stop him, giving even rituximab. And I can tell you the story He has 3 to 4 times hyperhemolysis repeatedly until at one time, I still remember, he texted me from Japan because he's a lawyer. So it was HB fell to 2.9. So we have no choice. Eventually, we counsel him. We actually subjected him for splenectomy and cholecystectomy on 27 March last year. And now his HB improved to 12.3. As you can see, he's on 6 weekly transfusion, 3 transfusion HB achieved back to 9 to 10 with the penicillin V, cardiopyrin, and Cerox only without Desferal. He's happy going to court every day now. Thank you. I think I will skip this. I will have a lot more slides actually. All right.
Thank you so much, Dr. Yap. Yes,
Screening
perfect.
and the of the thalassemia is instrumental to reduce the incidence and management of the disease. The treatment of thalassemia is evolving, and to me, prevention is better than cure. Thank you, Delaney.
Thank you, Dr. Yap. Much appreciated, and I appreciate the fulsome conversation. So, moving right along, I want to ensure we give time for our second panelist, Dr. Prantar Chakrabarti. Are you able to say hello, Dr. Chakrabarti? I just want to make sure your audio is working.
Yeah, can you hear me?
Yes, fantastic.
Yeah, I'm in the midst of another conference, so there might be some background noise. Don't worry.
Okay. Thank you so much for the disclaimer. So quickly then, you are the professor and head of Department of Hematology at the NRS Medical College in Kolkata until you decided to leave in July 2019 and develop the cybernetic care. You're a graduate of the oldest medical college in Asia, the Medical College of Kolkata, and you pursued your medical degree at the Institute of Postgraduate Medical Education and Research in Kolkata. In internal medicine and a postdoctoral designate in clinical hematology from the All India Institute of Medical Sciences in New Delhi. Prior to joining the medical college, you were instrumental in setting up the development of the Institute of Hematology and Transfusion Medicine at the Medical College of Kolkata, which is a center of excellence. And after joining the NRS Medical College as a professor in 2014, you shouldered additional responsibilities as a nodal officer of the Multidisciplinary Research Unit and were the principal investigator of the DBT NIDAN Center for Excellence in Genetics. You've also been the nodal officer of National Knowledge Network under the auspices of the NIC, and you're a subject matter expert in hemato-oncology subject expert committee at the CDSCO, Government of India, and nodal officer of the State Thalassemia Control Program in the Government of West Bengal. You're actively involved in designing and validating point-of-care non-invasive diagnostic devices, which can detect hemoglobin, bilirubin, and oxygen saturation levels in blood just by shining a light on the human eye. And right now, you're working with the Zoho Corporation to develop an accessible and affordable rural healthcare delivery model. So without further ado, please welcome Professor Prantar Chakrabarti. Over to you, sir.
Yeah, thank you so much, Delaney. I hope my screen is visible.
Yes, it is. Yes, it is.
Yeah. So thank you, Dr. Yap, for explaining thalassemia in such detail. But I'll do something different, because when we talk of LMICs, sometimes we fail to define why they are low and medium income, and there is a vicious cycle. But as far as sickle cell disease is concerned, I thought that there are certain unique challenges in the LMICs, and I would like to address them and try to find out whether it needs different way of managing. So there are two aspects. One is in identification, and the other is obviously in terms of management. So what are the unique challenges? The unique challenges in all the LMICs is that we do not have widespread newborn screening. We know that it helps detect the carriers, the diseases, and it helps manage the children, but we have not been able to do it. Obviously, we are trying our best. The second is that as a part of screening, we have a lot of point of care devices, right? Now, the problem is, in my country, what I see, I do not know whether it is true in Southeast Asia or in Africa, that there are a lot of POC devices which are not validated in that population study. So then you use it, and then when you try to validate it, you see a lot of false positive and false negatives. The other thing which Dr. Yap was speaking is very important, and that is a registry. So if you ask me today, how many sickle cell patients are there in India? So we have made an online dashboard at this point of time. We have screened around 10 million people, But still, if you ask me the number of patients, it will be a guesstimate, because India is akin to Europe plus minus the population of Australia and others. Another unique thing here is the moment you identify even a sickle carrier, there's a lot of stigmatization. There are social taboos, they cannot mix with their friends, and in terms of marriage. So I've seen marriages being broken when one was a carrier, the other was normal. They could have gone ahead. I have certified that, but it couldn't go on. Now coming to the challenges in managing SCD in the low and medium resource countries. Awareness. And for awareness, I first point my finger at us, the healthcare providers. So if you look at our standard textbook of medicine, you will see thalassemia and sickle possibly in 1 or 2 pages. But it's a public health problem in India with thousands of patients. Total number of patients would be in terms of millions. Awareness of the healthcare providers, awareness amongst the patients and their family members. We are fortunate enough that we have family members who participate in the care, but because of short consultation times, sometimes we fail to make them understand what the disease is, why they should drink water, why they should make certain lifestyle changes. Healthcare infrastructure. Yeah. Most of the LMRC spend less than 5% of their GDP on healthcare, right? We spend 30% on defense budget, but then obviously then the gaps are there, and the gaps are actually in the form of a vicious cycle. So you diagnose them late, you diagnose them with complications, and you spend more money and you have poor outcomes. Access to drugs. We are called the pharmacy of the world, but still in certain pockets in India, there are problems with access to hydroxyurea. And I am still waiting for our generic liquid formulation, which can be used in children, because the license has been given by our FDA, but I think the molecule, the formulation would be available possibly in 3 months. And sometimes the drug is available, but the access is not there because the patients cannot come to the center, right? They may live in hilly areas, they might not have access, and there is shortage of multidisciplinary care. Now, if I talk of my discipline, hematology, most of my students are interested in hemato-oncology. So who looks after the red blood cells? And you look at our journals, they are full of platelet and white cells. Red blood cell publications are the least. Fortunately, we are having some novel molecules now. But let me tell you another thing. Most of the trials of sickle cell disease are in US and Canada, whereas most of the patients are in India, Africa, and Latin America. So even in terms of clinical trials, you will see this skew and bias. Now, identification. So screening. Whom? Is it only newborn, or is it you also do it for school children? And then because India's population is 1.4 billion, right? You cannot screen everyone. It's not possible by even, if Elon makes robots who will do everything. So you have to be selective. For that, you need micro mapping where the prevalence is high. So once in our country, we thought that it was more prevalent in tribals and more prevalent in certain states. We started our elimination mission like that. Now we are seeing patients in other states also because of migration. People shift from one state to another in search of jobs, and you get the disease. But still, as a policymaker, I think that you have to take certain decisions because your resources have to be rationed. And then where do you do it? Obviously, the best is at the point of care. You cannot tell someone that, okay, I will screen you, you come 300 kilometers, you lose a day's wages. It is not possible. And how do you do it? So obviously, a CBC helps in thalassemia screening, but it does not help in sickle cell screening. So point of care devices, but as I told you, there have been spectrometric and then LFI based other methods, but they need validation in the population where you want to screen. And then you screen, okay, you detect a sickler or you detect a carrier. Then what? I have found people who said, I have been screened 3 times, but I don't know what to do. So it's an ongoing journey. And that's why we have made a web-based dashboard. So every person is GPS tagged and you have to see what is happening to them. Now, other than screening, obviously there's the question of diagnosing, right? So how early? Now, they usually in my country, they do not present before 6 months of age, but I think 6 months to 1 year is a crucial period and misdiagnoses do happen. Still, some of the young children are diagnosed as juvenile rheumatoid arthritis instead of sickle. So as I told you, the awareness has to be there and you have to make an early diagnosis if you have to prevent complications. By whom? Now, if your doctor to population ratio is not high, we have to train our workers. We have ashas who are there in the villages. If we train them, like Dr. Yap was telling us, about the basic rule of 3, CBC is available at least at the block level, which is beyond the district. So district is like a county. So at least they can look. And if they suddenly find a child has jaundice, if the child complains of pain or is incessantly crying, because I know that I'll not have pediatricians to my last mile, but you can train your paramedical workers. They can have a checklist, but they need to be aware of it. And then diagnosis, how, automated electrophoresis systems are there, but we, because of the ease of using automated HPLC, the district centers nowadays have HPLCs. So for confirmation, you can do that. For sickle, we do not need a lot of genetics, but as she was saying, for thalassemia, you have more than 300 mutations and there is some genotype-phenotype correlation. And then again, the question comes, you diagnose, then what? Do you make the patient understand? Do you make the family members understand what they have to do and how they have to come to me frequently and when they have to contact me when they face a problem? So there are challenges in newborn screening and early diagnosis in LMRCs. We know that these are problems: limited screening coverage, lack of awareness, public awareness, infrastructure gaps. And what we have done is we have integrated all the 3 inherited disorders. So it's thalassemia, sickle cell, and inherited blood disorders like hemophilia. So there are district control units who have been given this responsibility of identifying. Now, what do you do about the socioeconomic barriers? When you go to these hi-fi conferences, they talk of standard of care. What is a standard of care when you have not been able to provide a standard of living to the entire population? So that is a challenge, but you can do something. Even it's not only about drugs and it's not only about technology. It's about community awareness and helping us go together. Now, as far as diagnosis of sickle is concerned, the eyes cannot see what the mind does not know, right? So a lot of things go on and they can present to different people. So acute chest syndrome, you can see so many things go on. You might diagnose them as a pneumonia. I tell them, even if you diagnose it as a pneumonia, actually you use antibiotics. So that helps the patient. And we used to say, even for thalassemia, if you've read it well, you have understood the whole of medicine. Just like diabetes, sickle is a similar phenomena because it does not leave any organ. So you have to read about it. Now, previously, we were guesstimating our VOCs. This is a paper which we have published 5 days back in British Journal of Hematology, the burden of vaso-occlusive crisis. And today there is an editorial on this because, as I told you, the eyes do not see what the mind does not know. And the policy makers cannot make any policy unless they know what is the burden. So this is my colleagues, they have done in different parts. And I just want to show you the heterogeneity. So, in fact, each state of ours is like an European country. So each of them have different prevalences and their phenotypes are also different. You have to understand that these data need to be captured. And if you see the burden of VOC, home and healthcare management is quite high. It's 83.6 per 100 person years, right? And 76.4% had VOCs. Of all the hospital visits, 60.5% were due to VOC. And 70% of them, I'll show you, are on hydroxyurea. So we know hydroxyurea is the standard of care. We are trying to get it and give it. Still, you have this burden of VOC, which only shows us that you have to be innovative. So the VOC is only the tip of the iceberg, right? There are so many things which you have to take care of. But I think the recent global clinical trials, they're all taking VOC as the endpoint. So at least you have a hard thing to palpate and understand. Now, if I look at what has happened in the sickle cell field, till 2010, there was a lull in terms of discovery. 1910, it was mentioned. 2008, UN declared World Sickle Cell Day. Vectors were being developed in 2006, but then over the last decade, you had baby hug study, STOP2 for stroke prevention, TAP study for blood transfusion, and you had more flexible recommendations for transplant. Now in India, the transplant infrastructure also, the kind of transplants we need to do, we are currently doing only 8% of that. It includes obviously leukemias and other things. So you can imagine now if you want to transplant your sickles, the kind of healthcare system support you need. Genome editing technology has been there, and I'll speak about what we are doing in India after some time. So all of you know that there are 4 pillars of sickle cell disease management. One is supportive. For this, you do not need money, right? You need passion and you need people's sincerity. So they discuss about nutrition, exercise, general healthcare, and obviously hydration. So, in one state in our country, in the schools, we have water bells. So in every period, a bell goes on. The children have to take out their water bottles and drink water in front of their teacher. That is how we are trying to get it done. And it doesn't need money, right? So symptoms, analgesics, blood transfusion, antibiotics, in spite of vaccination. Then these are the therapies. Hydroxyurea has been with us. I think we manufacture the largest quantity in the world. L-glutamine is approved, but it's not widely available. Crizanlizumab is still approved here, but it has been withdrawn from Europe. And voxelotor has been withdrawn from all over the world, right? So it leaves you with hydroxyurea, but there are certain challenges which I'll discuss. And then HSCT is only like stem cell transplant is possible in few patients. And don't worry about these names. These names are like this, and the expense is also like that. So none of my patients, unless they're in clinical trials, can afford what is being offered in Europe and US. So established things are lifestyle changes, hydration. I talked of water periods, TCD monitoring. It's available in very few centers. In Nigeria, they have even trained nurses to do it. So you cannot tell that a radiologist who is interpreting CTs, MRIs will give time for TCD. So it's high time you get dedicated personnel to do it. Don't wait for, escalating the analgesics. Don't wait for starting antibiotics, even they are on penicillin prophylaxis. And you have to improve the vaccine coverage and stem cell transplantation. So these are already established. It's all that a management, a policy change is required in LMRCs to do it. And then novel molecules, gene therapy, and AI. Now, let me tell you, actually AI can help provide better care. So what we did is we developed our own guidelines. We taught it to the large language models like ChatGPT, and now the nurses can ask in their own vernacular language, this patient has come with these symptoms, how much fluid should I give if I give it at all? And it gives you a right answer, but there has to be oversight over AI. Now, where is the time, right? I don't know whether you can see it clearly. Can you see my country anywhere? So this starts with Sweden, USA. India is here, right? And most of the LMRCs are all here, less than 2 minutes. Now, in less than 2 minutes, how much will you tell the patient, right? How much will you look at? How much will you do? In terms of hydroxyurea, the other issues are the mindset of the health provider, problems in the health facility, and the patient's family. They think it's an anti-cancer drug. So we are not doing bad. We have published this that we are using in about 70% of our patients. Most of the time, there has been problems in compliance because of issues of drug availability and cytopenia. We are also doing a nationwide randomized controlled trial to decide on the dose of hydroxyurea. But I always tell my colleagues in LMRCs, don't feel guilty. Look at what US has done. Even in 2019, 38%, 53% are only on hydroxyurea. So it's not about high resource and low resource. It's all about how you manage it. So never feel guilty of what you're trying to do. And problem is actually an opportunity. You can do leapfrogging, you can improve access, you can take care of supply chain dysfunctions. So what do the LMRCs do? You enhance your infrastructure, you expand your workforce, not necessarily doctors, right? In our country, we are producing only about 100,000 doctors every year, and you imagine 1.4 billion people, right? Improve access, streamline the supply chain, and then you have to understand that capacity building and clinical research goes hand in hand. So get everybody, get the bureaucrats together and tell them. So we have had our guidelines published. These are all there in the public domain. What can we do? We can foster collaboration amongst us, not listen to US and Europe all the time, involve the communities, incentivize science, translational research, so that people invest in that out of the box thinking in terms of AI, digital health, but all of it has to be human centric. Just because a point of care technology is there and you have to fit it everywhere, that doesn't work. You have to know, and it's holistic care. There are certain things in Ayurveda and complementary medicine which can take care of these people. Use digital tools as we are using today. I think we can all work together. So though it's a long way to go, you remove the gap and you take along all people. Thank you so much. Think globally, act locally, and remember, others will not come to solve your problems. Your country's problems is unique to you. You have to solve it. Thank you.
Wow, fantastic. So folks, you paid audience to a fantastic session delivered by both Dr. Yap and some powerful calls to action by Dr. and Professor Prantar Chakrabarti. Thank you, sir. I feel empowered just listening to both of you, and I really appreciate that message to close the session. So we have about 11 minutes left for questions. There's been one question posted in the actual chat, and I hope folks had to have a chance to see it. And it's to your point, Dr. Chakrabarti, about, being human-centric, not losing sight of the human in the middle of the use of
Yeah,
digital tools like artificial intelligence, etc. And then
yeah.
likewise, there's been one question, it seems relatively specific, and I don't know if either of you are able to respond, but it says that an individual's wife and so the wife is AS, they are AA, and their firstborn was born S, their second is SC, and their thirdborn is AA. I guess they're trying to figure out what is the rationale behind the genetic distribution.
Yeah, so I don't think, because if one was AA and the other was AS, then where did SC come from, right?
Right. Yeah.
I think,
So
yeah, we can discuss it in another forum. They may
yes,
always share it and we will try to help them. And I think
perfect.
genetic counseling also needs to be percolated amongst the population, the community health
I
workers.
agree. I agree.
Yeah.
There definitely needs to be those resources in the community to help folks navigate those questions. So, folks, we have two great authorities here on the session. If you have any questions, now is your chance to ask a bit more, whether it be specific to the presentation, please, in and around, Professor Yap's case studies of what the actual context looks like in Malaysia, as well as Professor Prantar's conversation in and around LMICs, or sorry, low to medium resource countries, not bearing the brunt of thinking you're lesser than, but recognizing that uh, you're not going to likely see heroes descend on you and provide solutions. So it's incumbent on you to do so.
Yeah.
So are there any thoughts, any questions? Maybe in the interim, I can ask a question to you, Professor Prantar. You mentioned something about doctors are not the solution, or not the
Yeah.
only solution, right? And it's
Yeah.
because, as you know, it's a huge resource intensity to train doctors. How do you
Yeah.
think we can build capacity amongst our community in terms of without having the option of going to a secondary or graduate education?
Yeah, yeah. So what I think is right now I live in a village and I've
Hmm.
seen intelligent boys and girls there, right? So I'll tell you what we do in terms of engineering innovation. So we take them from class 10, 12, we
Hmm.
teach them English, mathematics, and coding, and they start earning also. Similarly, the basics of biology and how to identify, it's all about pattern recognition.
Yep.
So obviously, you don't teach everything with what you're teaching through your MBBS, your post graduation, postdoctoral. Since it's a problem in the community, you have to develop modules which give them the basic information. And the most important thing I've seen is if I can make them understand the red flags when they have to be brought to the health care. So there can be a checklist, about the vaccines, whether they have shown they have come once a year or maybe 6 months. But the other thing is that, okay, you have a child with jaundice. I've seen pediatricians, people coming to pediatricians so late that they have already developed other problems. So, what my feeling is, it's not about what you're reading, right? There are so many good videos. We can always make it context specific. And I see a great opportunity in AI being a friend rather than being a competitor who can provide you the information if you can make it context and perspective specific. I think any class 9 or 10 boy who is living in the village can be an ambassador for detecting early sickle cell and helping the patients understand why they need to do certain things and they don't need to do certain things. I might
Beautiful.
be criticized, because I promote barefoot doctors, but
Mm.
nurses are also scarce in my country. So, I mean, and then what happens is, in the government sector, you train a group of people, the next day they are transferred to another department. So then
Wow.
you lose it. So first is, I think, in terms of human resource identification, you get to know whether this person will be there and this person belongs to the community. That's why we have ASHA workers, and you might be happy to know that World Health Organization has awarded them the best healthcare resource 2 years back because they go from home to home. But unfortunately, they are overburdened. They have a huge list. But I think depending on what the priority is, we can train them and then we can get more people, incentivize them so that they get actually some self-actualization that they are doing something good for the community. And I think organizations like Gansett can go here and also give them some sort of recognition. That is important, that they have saved so many lives, they have touched so many lives. Sorry, it was a long answer.
No, I mean, it's an empowered one. And Dr. Yap, I don't want to leave you hanging, but we had one question in the chat that was
Yeah.
asking about sorry, it was in and around hydroxyurea, and the individual mentioned that a hematologist once stated that hydroxyurea should be prescribed irrespective of the degree of severity, I guess, of sickle cell disease symptoms. They're asking if folks would agree. So maybe
Yeah.
I'll present it to you first, Dr. Yap, and then Dr. Chakrabarti, if you want to respond as well. And folks, we'll be launching the poll now as well. So please feel free to submit your feedback to our speakers. Okay, over to you, Dr. Yap.
Yeah.
Yeah,
So
yeah.
Oh,
please,
Oh, yeah.
ma'am.
Prof,
Yeah,
you
yeah.
answer. Thank you.
No, so what I was trying to tell is, if
Yeah.
a patient has come to a healthcare center seeking help for symptomatic sickle cell disease, we use hydroxyurea, right? So
Yes.
severity and all, yeah, the studies were originally designed like that. Even I know Dr. Graham Sargent in West Indies never used hydroxyurea, right? But then that's a different ball game. The thing is, if someone is coming to you with symptoms, I'm not talking of asymptomatic ones, and I'll tell you something is unique in India, which is not there in Africa. We have high fetal hemoglobin levels, still we have severe phenotype. So sometimes hydroxyurea helps by increasing hemoglobin F. They have high hemoglobin F, but still they have a severe phenotype. But there are certain other things. I think the decision is individualized, but
yes.
they should be monitored. It's just not, we had a bike advertisement in India. They used to say, you fill it, shut it, and forget it. You can't do that with hydroxyurea, right? You have to monitor the counts, especially in the children, and then do it. And
Yeah,
I
Prof,
think Dr. Yap
in
can say about
Malaysia,
hydroxyurea and,
Yeah, in
NTDT
Malaysia.
and other things.
I just
He
want
did
to
that
share
helping.
my experience in
Yeah,
Malaysia, because we don't have much homozygous S. We always
yeah,
get sickle bed. So which essentially is very different when they present. They
yeah,
don't really get into sickle cell crisis, which I
yeah,
noticed those from Nigeria came over in Malaysia. They really present very severe acute chest syndrome, like what you described. That we have to, we even have problems to look for bloods for red cell exchange because we can't find compatible blood for them.
yeah,
Seriously.
yeah.
I'm serious,
And a
Nalini.
lot of have alloimmunization because they receive transfusion occasionally. So alloimmunization is also a problem, like you discussed the case.
We have one case that we have no choice. We can't look for blood at all in our populations.
Mhm.
The Nigerian lady, I still remember.
So, okay, folks, we have time for one last question. And I know there's many in the chat. So, and some folks, please do feel free to send your emails or your questions to the conference organizers, and we'll do our best to flow those to the respective speakers for responses. But one person's asking, and this is a lucky person, how can we incorporate PWDs, and I'm not sure what that refers to. I think that might be community workers to be part and parcel of the campaign. Like here in Kenya, many people living with deafness who are either parents, caregivers of sickle cell disease are often not included in the awareness campaigns, and communication is a barrier when they're seeking health services in the hospitals. Great question. So maybe over to you first, Dr. Yap, and then you can close things out for us, Dr. Chakrabarti.
I'm sorry, you're saying that how do we actually, can you repeat that question again? Sorry,
Yes.
Delaney.
No apology necessary. How can we incorporate people living with deafness to be part and parcel of the campaigns, like these social awareness campaigns? So basically, this person's mentioning that many people in Kenya are living with deafness and the inability to hear, and are caregivers of folks living with sickle cell disease. So are there ways we can think about incorporating them into awareness campaigns and ensuring there's no barriers for them to seek care?
What we do in Malaysia, we have a lot of support, like thalassemia patient support group, and we have a thalassemia society. I just show what I experienced in thalassemia. Fortunately, cell is not really huge. It's only like 10 or 20 patients we have.
Oh,
So
wow.
that's why most patients, when they encounter like this kind of like going to palliative care, I think with the death, right? You're saying whether
Yes.
how do we incorporate all the support. So
Oh,
we have
sorry, deafness,
sorry.
so not end of life care. I meant to say people living with hearing loss or inability to hear.
All right, that's from sickle, right?
Yes.
Yeah, I think I to be honest, my experience handling sickle cell is not much in compared to
Okay.
Professor Chad. I think better
Sorry,
you
Dr.
will
Yap.
answer this question.
Perfect. Thank you,
Thalassemia,
folks.
I'm
Sorry.
much.
Yeah. So mine is also,
That's my mistake.
out
Over
of
to you.
2,000 thalassemia patients, I have only 32 sicklers. So
Oh, there it is.
anyway, but yeah, that's a very good suggestion. And, so you will say there's a communication gap. So you need someone with the sign language, but nowadays you have very good voice to text, text to voice, and other visual cues. But one thing works very well, and I think we can be the leaders in this, is get the patients. I call them patient ambassadors. There are some smart patients who have understood. Let them counsel other patients. So
Beautiful.
if you think that someone has hearing impairment, maybe sign language, someone would have picked it up, right? And now we even have tools. But even if there are no tools, sign language, one patient, if he or she has picked it up, let that person explain to others. But you have to
Beautiful.
first understand that there is a need, right? There is a gap in communication. Yeah.
That's it.
Thanks for the question. Yeah.
I mean, fantastic response, fantastic question, and you know, on that resounding note, we all have a role to play. So, with that being said, folks, we've come to the close. I know could spend another hour with these two beautiful speakers, but unfortunately, that is all the time we have today. 10:20, we'll have two more sessions for you to participate in, our two concurrent sessions. So, the first being benefits and risks of curative therapies and inherited blood disorders, where you'll have a panel of three experts discuss the topic from sickle cell disease, thalassemia, and hemophilia perspectives. It'd be patient perspectives. And then following, we'll also have at that concurrent time, the improving health outcomes in inherited blood disorders transplantation and inherited blood disorders gene therapy for sickle cell and thalassemia, managing bleeding and thrombosis complications. So if you haven't already filled out the poll, please do. As mentioned, if we weren't able to get to your questions, please submit them to conference organizers. We'll do our very best to try and get those responses back from our speakers. But without further ado, you all have a 10-minute break now. Sorry, 9 minutes. I know I creeped into your 9-minute break. Please feel free to take a bio break, and then we'll see you back quickly or shortly at 10:20. And big thank you once again to you, Dr. Mandy Yap, Dr. Prantar Chakrabarti, for your fantastic presentations. On behalf of Gansett, we really appreciate your contribution.
Thanks, Delaney.
Thank you.
Thanks.
Thank you. Take care, everyone. See you at 10:20.
Yeah.
Yeah.
Bye.
Bye.